All right, I'm going to go ahead and get us started. I'm sure we'll have a few folks continue to trickle in person and on Zoom, but we'll get started here. Welcome, everybody. So happy to have you for our afternoon of faculty development for teachers in the Longitudinal Integrated Clerkship, or LIC. We have a great program for you this afternoon with 4 sessions scheduled. We'll start this first hour with a session that the curricular team calls LIC 101, going over what is an LIC, what are the changes in the CEU curriculum that have happened in the last 5 years in broad strokes, why some background is into why those changes happened, and then giving you some vocabulary for the staffing and structure of the LICs, both from the top and at your local level, so you feel empowered around if you have a question who you can use to. The second hour of our program is going to be all about assessment and evaluation. That's going to be led by Dean Adams, and we'll walk you through the program of assessment that's used for LIC students, the rationale, and try to give you some practical tips and maybe even some time to practice around what makes a high quality assessment for an LIC student. For the third hour, from 3 to 4, we're going to split into groups depending upon your area of practice, and we will get into that more when we get there, how to choose what session to go to. But in this room, we'll be doing a session that is zoomed in on teaching in the OB-GYN and surgery setting. And then in breakout rooms across the hall, we'll have one session going on outpatient teaching. So if you work only or primarily in the outpatient setting, non-surgical, there'll be a room for you there. If you work only or primarily in the inpatient setting, there'll be a teaching in inpatient and hospitalist setting there. That's going to be run, those talks are going to be run by internists, but they're going to be broadly applicable to outpatient and inpatient across specialties. If you're on Zoom, we will help you get into breakout rooms on Zoom as well. And if you're not sure which of those rooms is best suited for you, or you don't fit any of those categories, come talk to us in between and we'll help you figure it out. And then from 4 to 5, we're going to have an optional session for anyone who is new to teaching team-based learning, which is the didactic format that we use in the LIC for most of our didactic content. So if you're signed up for that session, that will be happening from 4 to 5. Any questions about our agenda for the day or the plan? That all sounds good. Great. If you're on Zoom, if you have questions, please feel free to drop them in the chat. We've got Kirsten and Andra here helping monitor the chat and will alert me. I definitely do not have the bandwidth to monitor in this hybrid format while going through my slides, but Kirsten and Andra are on it. Or also please feel empowered to just unmute and shout them out, and that way I'll hear it right away. I'll try to leave about 10 to 15 minutes at the end of this session for questions and transition to the next one as well. All right, so let's jump into LIC 101. I'm Kate Adkins. I am an assistant professor of OB-GYN at Denver Health, and I am an assistant dean of medical education for the clerkships. I am a former LIC director at Denver Health before I came to this role, and a LIC preceptor of many students over the last 5 years. So lots of experiential teaching expertise to offer there. These slides were largely prepared by Dean Adams, who is professor of medicine at the Associate Dean of Medical Education and the person who led the charge for bringing our all LIC model at the University of Colorado to reality. So a few learning objectives for this first session today. We want to empower you to support your LIC learner and enhance your teaching experience by giving you some understanding of the nuts and bolts of the LIC. we want to give you a plan to approach your first day with your student and ensure a great year together. Some of you may have already had your first day with your student, so maybe a plan to approach your first sessions with your student and ensure a great year together is better wording. And then help you identify teaching resources that you can use to build upon the knowledge that you'll learn in this afternoon together. This is a timeline of our transition to an all LIC model for the clerkship phase of our curriculum. LICs have been around at the University of Colorado for a very long time. In the rural program, LICs have existed for 14 years now. The first LIC program in the Denver metro area was started by Dean Adams at Denver Health in 2014. And then the program quickly expanded to include the VA and the Colorado Springs branch. So although all LIC is relatively new, the concept of LICs at the University of Colorado is not new at all. And part of the driver for the curriculum reform in the clerkships here was the success of these LICs across the states in the state in the different locations. And we were able to build upon the success of these as we moved toward expansion to all LIC. Our full curriculum reform plan was fully rolled out in 2022 when we transitioned to all LIC curriculum for the clerkship. So all of the students in their clerkship year were placed in LICs for the first time in that academic year. And that included 200 students who successfully moved through the first year of the all LIC curriculum. So we are now in our fourth cohort, LIC 4.0, who just started with the start of this new academic year. I think it's helpful to see the schematic of what we mean when we're talking about the Foothills curriculum, where the clerkships are situated within the reformed curriculum at large. And so the view from 10,000 feet of the new curriculum is a journey from the plains to the summit in true Colorado fashion. And each of these phases map on a curricular phase where the students are working on specific objectives. So the preclinical time in our new curriculum is the plains. This is the time when students are doing classroom learning, which is done in a systems-based fashion, and also starting their clinical skills work from day one. They work in small groups to form bonds, start to form bonds and connections in small groups of their peers as they move through the preclinical content in the classroom, as well as the clinical skills curriculum where they're starting to learn the skills they'll need when they come to you, as well as health and society content, which covers social determinants of health and the like. Students also have longitudinal preceptorships during the Plains curriculum. And so though it's the preclinical part, they are already getting clinical exposure. They get a short break from the classroom in the summer between first and second year, and then we all are at the start of the Foothills phase in the current academic year, and Foothills is the phase that continues the longitudinal integrated clerkship. The students aren't doing any additional classes or courses within the Foothills. The longitudinal integrated clerkships and the work that is associated with that and learning that is associated with that. It's where they devote all of their time through this academic year. And this runs from the base camp, again, fitting into this journey up the mountain scheme. We've got base camps in which they get their orientation in September, and then the LICs run all the way through August of the next year. After they successfully complete their LIC, complete the Foothills, they move into the Alpine, which includes all of the content in a traditional curriculum that happens during fourth year including acting internships, and then a lot of additional content because the students now have 2 years after they finish their clerkships. So they move through advanced science courses, which happen both in the classroom and in the clinical setting. They have a chance then to choose a trail, which is can think of it as a concentration of learning that can help guide their some of their elective time during their 3rd and 4th year. And then they are applying for residency at this time of their 4th year, of course. The Alpine is also the phase where students take their step 1 and step 2 USMLE. All the students end their time in the new curriculum in the summit, what we're aiming for across this track. And this is mostly inclusive of transition to residency courses that are individualized by specialty for the students. And that's the broad overview of the new curriculum. I think things to know about it or to notice about it mostly are the shortened time before clerkships, the devoted time spent in clerkships during the 2nd year of the Foothills, and then the variation and personalization that is possible for the students during year 3 and 4 in the Alpine. So we're now going to zoom in on the Foothills because that's where the LICs happen. There are 16 individual LICs spread out across systems and across the state of Colorado, ranging in size from 4 to 15 students per LICs. The LICs on the Anschutz campus account for a little under half of the students in the class. And on the Anschutz campus, we have LICs that are primarily based at Children's, primarily based at the VA, and then 4 LICs that move across different settings on the Anschutz campus. The LICs at Children's and VA use preceptors at other Anschutz and UCH sites for specialties that they don't that they don't have in-house. Denver Health has 2 LICs. The Northern Colorado branch has this is listed out as 3, but really functions as 2 LICs with students in Fort Collins and students at Longmont Boulder. Kaiser houses an LIC, the Community Health LIC, where students do their outpatient work at in-clinic systems, including Salud, Clinica, and Stride. The Rural LIC has students all across the state in different communities where they'll spend their clerkship year working with preceptors in rural communities. And then Colorado Springs branch has 3 LICs, including a small LIC at the Colorado Springs Children's Hospital. So you can start to see here this representation of diversity of clinical sites, both geographically and based on the focus and resources present at a given hospital or health system where students spend most of their time. So after that, with that roadmap in mind, let's talk a little bit about the structure of an LIC and the vocabulary that you need to know to understand this curriculum a little bit better. The foundation of an LIC has everything to do with longitudinal care and continuity in many, many aspects of the word. And so the principles of the LIC that hold constant across all of these sites and all of these varied learning communities are that this is a structure that allows students to participate in the comprehensive care of patients over time. So our curriculum is structured to allow students to meet and care for all sorts of different patients in different specialties and clinical settings, and then follow those patients and continue to participate in their care in the other settings and other touches that they have with the healthcare system. The second core piece of continuity and longitudinality in the LIC is continuous learning relationships with their patients' clinicians, and that's all of you. And so we'll talk a bit more about how the students spend their days, but in broad strokes, their calendar is structured such that they're having multiple touches over the course of the whole year with a smaller group of clinicians rather than the doc of the day that may be rotating in and out on labor and delivery, for instance, in my world. The final core principle of the LIC model is that students meet the majority of their core clinical competencies across multiple disciplines simultaneously. And I think this picture on the next slide helps illustrate what we mean by that. So above you see a representation of the traditional block model in which students move through the specialties, their clinical specialties in their clerkship year in chunks. So this is pretty easy for most of us to understand. Most of us, this is the model that most of us probably learned in, with a few exceptions, where you spend 3 months on internal medicine, you learn the clinical competencies there, then you move on, different clinical site, different preceptors for the next block or chunk of your time. And this is how the clerkship has been done traditionally for a long time. In the LIC model, instead of marching through these specialties and their competencies sequentially, all of the specialties are woven together so that students are getting exposure to a variety of specialties in a given week, most weeks, and simultaneously working towards competencies across specialties rather than one at a time in blocks. And so what that looks like for a particular student schedule is the following. So all of the students have calendars of some variety that the LIC staff helps them put together that tells them where they are going on a given half day of the week, and their time is filled by scheduled time with their preceptors in each specialty in a recurring fashion. So a student may work with their PEDS preceptor every Monday morning, with their IM preceptor every Monday afternoon, etc. All of the students have learning seminars that happen for a half day of a week, and that looks a little different depending upon what LIC they are in, but learning seminar is always going to take up a half day of the week, and we'll talk a little bit more about that. And then the students have a small amount of time in their schedule, usually about 10 to 25% of their time is indicated as extended learning time. And what that means is that the students are not scheduled for a clinical task during that time, and that is the time that students can fill in pursuit of their own interests and in continuity with their patients who they are following across the system. So if my student is not scheduled with a preceptor on Wednesday morning, but they have a patient who they helped deliver is coming in for her postpartum visit on Wednesday morning, the student can then attend that visit on Wednesday morning and participate in the care of that patient. And so there is enough structure in this schedule that there's predictability and the students know where they need to be, and the students are meeting requirements for clinical hours in all the specialties, and enough flexibility that they can follow their patients and follow their interest in this extended learning time. For a much smaller chunk of the year, students spend time in inpatient immersions in the 5 specialties that are listed here on the right, over in the blue section. And so immersion time is usually a week, up to at the maximum 4 weeks at a time, where students instead of spending time with their preceptors, are going to spend the whole week with inpatient teams. And so this looks more like a traditional block model, but is not meant to be a condensed traditional block model or a replacement for the traditional block model. Rather, it is to expose students to the inpatient setting to allow them to develop the skills, learn about how things work in the hospital so that they can support the longitudinal care of their patients. And so this allows students to learn the language of the inpatient rounding teams that they're going to need in the future for residency, and that they're going to need if their longitudinal patient is admitted, and they're going to go around with the team on that patient and participate in their care during the admission. The inpatient immersions also allow students to focus on the care of acutely ill patients and gain some of the core competencies that are required for that they may see less in the preceptor setting if their preceptors practice primarily outpatient. It allows them experience with admissions and discharges, lets them learn the format of oral presentations, notes, and consults that can look different in the inpatient space, learn about how teams work together in the hospital, and do some career exploration, get exposure to the breadth of specialties that they may be seeing just outpatient with their in their preceptor setting, or specialties that they might not see in the outpatient setting otherwise. So that's an immersion. And again, students spend a range of time on immersions depending upon the LIC, but are usually stepping away from their preceptor schedule, like you saw in the previous slide, to go and work in the inpatient space for a couple weeks at a time. A few of the LICs cluster all of the immersions at the beginning of the year and have students join their preceptors then in December or January. Most of the LICs intersperse the immersions throughout the year. So you may notice that your student is gone for a couple of weeks because they're away on their pediatrics immersion, and then they come back to their preceptor calendar, like I showed before. Students are, one of the requirements of the clerkship year is that students, excuse me, develop a patient panel. And so early in the year, we encourage the students to cast a wide net to identify patients that may be good patients to add to their panel and follow longitudinally over the course of the year. And when we have our 3 p.m. session where we go into some specialty specifics, we'll talk a little bit more about how you can help your student identify a good patient for their panel. But really, any patient who you expect is going to have future touches with the healthcare system is a good patient for the panel. The idea is that students serve as primary points of contact, advocates, and navigators for their patient through the clerkship year, and that they can follow and help care for the patients wherever they go, which could include scheduled outpatient visits, admissions, procedures, deliveries, surgeries with patients from their panel. Again, the idea being if the patient sees or if a student sees a patient in their family medicine setting, connects with that patient, find something about a disease process that patient has going on interesting, find something about that patient's identity or social situation interesting, sees that the patient has an upcoming visit with a specialist, the student is empowered to attend that visit, to coordinate with the specialist and use the resources of their LIC team to help with that coordination, and attend it, which allows them then to access all the learning that's happening in that space, even though that specialist that they're seeing is likely not one of their preceptors. There are some guardrails around how to build the patient panel. So if I have a student who is orthopedic surgery or bust, they cannot have only orthopedic surgery patients on their panel. They have some guardrails around types of patients that they needs to be in their cohort so that we make sure we're ensuring comparability between the students and between the sites so that they're seeing patients in broad buckets, such as surgical patients, OB-GYN patients, pediatric patients, cancer care patients, chronic disease patients. These are some of the buckets that are required for the cohort. And then there's a lot of free choice in the cohort. So if the student is crazy about ortho, all of their cohort patients can have touches with orthopedic surgery, and they can follow those patients pre, intra, and post-op, and also to their other venues that they may be seeking having touches with the healthcare system. In order for a student to be able to count or include for our tracking purposes, a patient in the cohort, they have to have 3 separate touches with that patient, and an admission generally counts as 1 touch. So we don't want students to build their cohort saying, yep, I admitted this patient, I rounded on day 2, I rounded on day 3. We would count that as 1 touch, and then say if you went to their hospital follow-up, that's your 2nd touch. If you went to their scheduled surgery in 2 weeks, that's your 2nd touch. And the like. And we find that students tend to have no problem meeting these minimums, and students that are really embracing the structure of the learning will have far above and beyond the minimum requirements for their panel. I made a mention of team-based learning briefly when we were talking about student schedule. This is what that's all about. Each LIC has a half day of didactics in which the students participate in small group interactive learning. Team-based learning is a really tried and true educational method that supports the development of clinical reasoning by having students work together as a group through cases and gain foundational knowledge about important topics across specialties and healthcare domains through working together through those cases. It's meant to foster a growth mindset and peer teaching. I taught a TBL on abnormal uterine bleeding on Wednesday, and the students would give an answer, and they kept laughing at me because my response to their questions was always, well, what do you think? What does the group think? That's how TBL is meant to work, to draw the answers out of the group and help them work together through peer teaching based on pre-work and pre-reading articles that they have access to before the TBL. The team-based learning is developmentally progressive, meaning the students encounter harder cases as we go through the year. And then learning seminars also integrate some content of health and society. That's sort of social factors of health curriculum that goes across the phases, and also integrates clinical and medical science pillars, such as pathology and pharmacology, into the team-based learning sessions. So it's a pretty cool way of learning, and I hope that all of you will, or many of you will have the opportunity to teach or participate in this. And if you're interested about learning in learning more about that, our 4 to 5 o'clock session today will be all about team-based learning. So now that I've given you the foundation of how our LICs look, how the students move through this time in the University of Colorado clerkship structure, I just want to give a little bit of background about why. So this is all fine, but why did we take this thing that's been done for decades and decades, traditional block model, and blow it up to create these LICs? Most of the initiative for curriculum reform was due to the challenges for medical student learning in the traditional clerkship model. I think that many of us who taught students in that model can resonate or can identify with the idea that we encounter increasing challenges in facilitating authentic roles in patient care for students in the traditional block model. We encounter increasing challenges in helping students have exposure to undiagnosed patients. And the block model tends to blind students to the way that medical care really works by not giving them access to what happens after my patient is discharged, what happens when my patient goes to the specialist outpatient, what happens to this patient once they leave the hospital. And so these are the sorts of challenges and limitations of the traditional block model that made the foundation for thinking about what an all LIC model would look like. This is a quote from an LIC student. The main strength of my LIC is its implicit assumption in its structure and execution that clerkship students are capable of doing meaningful substantive work. And that's really a huge part of the why for this, to empower students to be meaningful participants in the care of their patients. You don't have to dig very far to see popular press and academic articles sounding the alarm about some of the challenges in the traditional block model. And a lot of this movement shaped a lot of what went into our curriculum reform. And then there's a lot of educational theory, learning science and adult learning theory that goes into why learning medicine in this way rather than in chunks by specialty is great. And so we know from educational research going way, way, way back in lots of venues that space review works to facilitate retention. And so probably all of us who have moved through medical education know what it's like to cram and to learn something for the test and then to move on, take your shelf exam and move on to the next thing, right? And that is not a setup for retention. But to have that topic come back up again and again and again is a great way to make it stick and to get students on the learning curve, which is the curve in green, rather than the forgetting curve, which means I crammed it, I saw it, and then I never saw it again, and I quickly forgot it. This is a graphic that we invoke a lot when we're talking with students about the value of putting in longitudinal work in a given specialty. And this is a concept called the J curve. So on this diagram, the x-axis is time. And then I like to think of the y-axis as sort of like performance, or you can think of it as learning, how a student is doing in a given specialty. We know that when a student is immersed to or thrown into a specialty, the learning can actually go backwards as they figure out what they don't know, as what they don't know becomes apparent, and they encounter challenges and frustration and unfamiliarity. Students can actually, the learning can go in the opposite direction that we want, and competence and performance can go down. And so if we're working in short chunks of time and students do not have time to find the integration part of this curve, which is the bottom of the J, and move into the return part of the curve and improvement part of the curve, the upward slope, then we may never be able to capture the full learning potential of an experience, because if you have a short exposure, you never get there on the time axis. And so our students in the LIC can really struggle when they're on the beginning part of this curve, the downward. Everything is new, because everything is new in multiple specialties. So if you can remember the feeling of what it is like to be the new kid on a rotation and then take that times 8 all in the first couple weeks of your clerkship year, that's really hard, right? And this downward, being on this downward curve in multiple specialties at once can feel terrifying to the students. And so all the LIC directors are really well trained to support students through that and to show, I have often drawn this on my whiteboard for students to help reassure them it's okay that you're on the hard part of the curve now, because our curriculum is structured to get you to the upward curve. And then I always tell my students that the linear slope up is totally unrealistic, and I need another name for this curve where once you're on the up, you're oscillating and have your bad days and good days. But the overall trajectory of learning over time, if students are given enough time to integrate and enough space repetition, is something that we see as a huge advantage to this model. And then finally, this is a visual representation of some of the concepts that have been mentioned on previous slides, just another way of showing why revisiting concepts over and over at a spaced interval
can help make the learning stick rather than learning those concepts in chunks. So the concept of interleaving or spaced repetition strengthens memory association. The brain is continuously engaged at retrieving different responses, bringing them into short-term memory. And repeating that process can reinforce neural connections between different tasks, correct responses, which enhances learning. So that's why our schematic of the LIC with all those bars running simultaneously is modeled after an interleaving model. And so LICs build on all of that educational theory around spaced repetition, interleaving, and the time it takes to get on the upward trajectory of the J curve and turn it into practice. And I'd like to review now in the coming slides how the growing data for how LICs can help support superior academic achievement and other non-cognitive outcomes that we want to see in our future physicians and students, and how it can improve the experience for faculty as well. Part of the non-cognitive benefit of the LICs is the reframing of the role of the student into an authentic and contributory member of the team. And so if we set up our students to feel like they share responsibility for patient care with the faculty rather than glorified shadowing or being the lowest person on the hierarchy of a very large team all the time, rather than working closely with their preceptor, we can help transform. We can then help build students who will carry that concept forward to be better team members, better care providers on day one in residency, navigators for their patients, and advocates for their patients, because they will walk into their residencies understanding how healthcare systems work. Maybe not the system that they're in, but they will have spent a whole year in one healthcare system learning how patients move through the various locations. We think a lot about entrustability, the concept of entrustability, and we'll get into this a bunch more in the assessment talk that's coming next. But at the end of the day, when the rubber hits the road with a med student, an outcome that we care very much about is, what can I trust this student to do? I am training this person up such that we can trust them to go on and be a good resident and ultimately a good physician. And those trust, there are multiple psychological factors that go into trust, which I'm sure you can think about both in the context of medical education and in the context of everyday life. How you come to trust a person or an entity. But one major component of trust is longitudinal relationship. It is really hard to trust somebody who you just met and know nothing about. And so in my practice, if I have a student who shows up on the first day of their rotation, walks into my OR to do C-section, is like, "Oh, I'm going to do a C-section with you," I don't know what part of this bad surgery the student can do. I don't know what they've been exposed to. I don't know what they've done before. So I'm much more likely to have that student observe. And I have, and I can feel justified in doing so by saying, like, that's the safest thing for patient care. I don't know what they're going to do, so they can do, so they are just going to watch. And that happens much less when we get to know students, right? So if I have them watch the first time, but then they're back with me the next week on labor and delivery, and I say, okay, this time you're going to progressively participate a little bit more. Pretty soon, I know exactly what they can do and exactly what I can trust them with. And then students can earn a progressive level of responsibility compared to a student who has to walk into an hour with a different attending each time they come in. And so entrustability, being able to get a sense of student entrustability in these longitudinal relationships is huge and is an integral part of our assessment program, which we'll talk more about, as I mentioned. Students also develop a holistic approach to patient care and a sense of responsibility to individual patients, which is a key component of trust to me as well. So if I have a student that I have trained up, I can see what they do, and I know that they understand my system, my expectations, and how my patients move through their care. I know I can tell a student, leave a student in the room and say, can you make sure this patient gets scheduled for the follow-up that they need, and make sure that that their after visit summary is correctly filled out. about. And I know that my students in the second half of the year know just what to do for that, and I can trust them to do that so I can move on to care for other patients. And that is huge, and something that I don't think many of us are likely to have ever experienced in a block model. This is a representation from an LIC outside the University of Colorado from some research that was done that informed some of our curriculum reform. But this is a graphic that shows how students who are in longitudinal curricula spend less time just observing and more time doing. And so on the left, we have block model students. On the right, we have longitudinal students, and the aqua color is time observing. You can see much less likely to be just observing. And then the dark blue and the white are assisting with performing with assistance or performing alone. And you can see how students in this longitudinal model spent much more time doing in the zone of the white and the dark blue. And this is going to look different in different clinical settings, and this is going to look different over the course of the year. These are students looking back on their year at the end of the year, and so this will be dynamic for students, but the overall trend is toward more entrustment to do more. And then, of course, we care very much about academic outcomes and want to ensure that students are doing just as well on all the metrics that are that we use to assess student performance. There are multiple studies that are listed here at the bottom of the slide if you're interested that show that students in LICs have equal or better performance on standardized exams, clinical assessments, sub-Is, board exams, and residency matches, all of which are hugely important to our students' success. And we have the benefit with the advent of LICs of this being its own experiment and being able to compare one class to the next or a few classes before and after. So we have a really nice natural experiment to see how students are doing when schools transition from traditional block model to LIC. And speaking of the match, we have at this point many years of students who have done their clerkships in the LIC and then gone through the match, and our students have performed fantastically in the match, matching in almost every specialty, maybe every specialty that's in the match is represented here. I don't know. I'm not 100% sure about that, but certainly an impressive list. And students go on to any specialty of interest, regardless of their time in exposure to that specialty in the LIC. So I think sometimes students are really worried. Well, I want to do derm and I don't have a dermatology preceptor, and the flexibility and access to patients in the LIC model means if a student sees a peds patient who's going to the dermatologist for some reason, peds dermatology or consulting, having a consult for peds dermatology, they have an automatic access to dermatology, and because of their flexibility to choose their own adventure in their cohort panel, they can build up a panel of patients with interesting dermatologic problems and then gain connections with those potential mentors. So the core, the small group of core preceptors that students have are not the only clinician mentors that they have access to in the LIC year. And I think that's very well borne out by these outcomes. And then I could show you, endless slides about performance and metrics. But really, with the bottom line of this curriculum reform, the driving factor that tipped the scale was a non-cognitive outcome that students in LICs demonstrate improved measures of patient-centeredness and increased empathy. And so our hope of building doctors who are able to connect with their patients and provide empathetic and patient-centered care was really the true north, with all of the additional theoretical and evidence benefits that I've shown on the past multiple slides. This is a graph that shows students who graduated from the LIC. The leftmost are students who graduated from LIC in the top line, solid line, and students who went through a traditional block model in the same institution in the bottom or dotted line. And then the x-axis here is moving through time from pre-clerkship to post-clerkship to follow-up, and the follow-up time was 4 to 6 years later. And so these students were compared on a scale of patient practitioner orientation scale, which is a validated scale for patient-centeredness. You can see when they started their clerkships, the LIC and non-LIC students were similar. At the end of the clerkship, their patient-centeredness had diverged, with the LIC students scoring higher on patient-centeredness, and then that effect held 4 to 6 years later. So it wasn't just a temporary glow and a feeling good from getting to know a bunch of nice patients and having them in your cohort panel. Really, it was a change. Something about these learners changed and persisted into practice, even in the years of life that are potentially most likely to challenge your patient-centeredness at residency training. So this is really our why. So we've talked a fair amount about the LIC impact on students. So now let's switch gears to think about the other participants in the LIC, the teachers and the patients. We know that there are some potential increased demands on faculty in this kind of intensive longitudinal teaching of students, including the possibility of increased time pressure for preceptors. I'm sure anybody who's had an LIC student with a clinic might understand that. And the potential for cost to fund the model. And there are many studies that show, that we'll walk through in brief here, that show the weight of increased preceptor satisfaction, development of a community of practice, and ability of students to meaningfully contribute in patient care that can be really positive, supportive, and protective factors for faculty. This study comes out of the CU model and surveyed preceptors at the end of the first year of the Denver Health LIC. Almost all of the faculty who were surveyed were satisfied with the LIC, but satisfaction isn't really the metric that we care so much about. I think the other metrics are more interesting, including increased overall job satisfaction as a result of teaching, and higher satisfaction in reward and teaching in the LIC compared to block models. And those are pretty remarkable numbers. So the LICs are invested in retaining these excellent faculty and making sure that they get the benefit of teaching and working with LIC students. You, the faculty, are of immeasurable value to this program. It just does not happen without you. And again, students recognize that the preceptors are the heart and soul and what makes this program happen. And so these quotes, which I won't spend too much time on, but you could read here since we're running up against the end of our time, are some student quotes illustrative of just how much their preceptors meant to them. And so this is an enormous cause for gratitude for all of you who are here in this room, whether you're experienced preceptors getting a refresher or just learning about this program. We have tremendous gratitude for you for being here, for teaching, and you are the heart and soul of this. And then what's the impact on the patients who are cared for by LIC students? patients who participate in LIC student panels who are cared for by LIC students alongside their preceptors. Report valuing the therapeutic alliance that they had with LIC students, voice improved patient experience, report improved health outcomes, and a multitude of other improvements or benefits of their care as a result of having an LIC student help care for them. I think this quote at the bottom of this slide is another just perfect representation of our why. And this comes from a study of the Denver Health LIC, which the patient said, he snuck in to see me at the ER, talking about the LIC student, that made me feel like I mattered to him. He didn't have to be there. And so this impact on the patients who interact with the LICs with LIC students and are cared for by students across our network is a huge part of the why. This is another study that looked at students who or patients who were cared for by providers working with LIC students versus not. And patients who had touches with LIC students reported greater satisfaction in a variety of domains and greater overall satisfaction with their healthcare, which is pretty remarkable. There's a large additional body of data to support that the idea that students training in a particular community may form bonds with those communities that may cause them to want to stick around or come back. And we've seen this happen in our LICs in the CU model that have been around for a bit. And it's another driver at based in our commitment of helping build up the workforce for the areas that need it most. So we'll spend our last couple of minutes here just reviewing some of the vocabulary. Now that you all are totally convinced of the value of the LIC and you've heard me for the last many slides talking about the why, now what? What do we do? How am I supposed to work with these students? And what makes me good at this? And we're going to spend the last few minutes of this hour and then a lot of the next 2 hours trying to get at some of these questions. So the LIC team is made up of these individuals. The preceptor is you. That's the clinical teacher that the student is assigned to work with in a given specialty over the course of the year. Each of those LICs, if you think back to that map that I showed you with the rectangles, have one or two directors. The directors are the leaders for the students in that LIC cohort and help organize the curriculum, delivery of the curriculum for those students, help organize the learning seminars that happen a half day a week, and meet regularly with students to review their progress. Liaisons you can think of as the site director for a specialty. So within, let's say, the VA LIC, there's a liaison for internal medicine, for surgery, for OB-GYN, and that is going to be the site director for a specialty. And those are folks that are going to help oversee the clinical experience for students at a site in a given specialty. And then the clinical content director, you can kind of think as a former clerkship director. They oversee the liaisons. They are a centralized leader who oversees the liaisons at all the different LICs, all the different sites, and helps develop this specialty specific curriculum that's delivered in the clinical space and in the team-based learning sessions. Additionally, each LIC has a coordinator. The coordinator is we say this so often in LIC spaces that it becomes a cliche and a joke, but they are the glue. They are the person who knows all the student schedules, knows all the personnel, and helps manage those schedules, which can be incredibly complex as the students move through so many different spaces. They help coordinate flexibility for the students to ensure that the students can see those panel patients. They help keep track of the students' time in clinical spaces, assignments, and assessments. And so if you ever have a question about your schedule or really any student question, a first pass person to ask the coordinator is never a bad idea. So make sure you know who your student's coordinator is, make sure you know the best way to contact them, and have them on speed dial for any logistical schedule concerns. How do I help my student prepare for their first day? Another just kind of logistical thing to know. These students, as we mentioned, are embarking on the huge task of starting to learn all specialties simultaneously, and they are going to be coming in with some nerves and some anxiety and some desire for expectations. And so consider carving out some time at the beginning of your relationship. If you haven't met your LIC student for this year, this is an opportunity to do that. If you have, maybe a check-in after a couple of sessions to make sure that all of these agreements and our expectations are set, get to know each other, help with the student's mind at ease around some logistics, and help share some expectations for the students. If you're not sure what this would look like in your practice or for your specialty, we will talk about this more in the 3 to 4 o'clock session. How do I make sure I'm a great preceptor? Most of the work of being a great preceptor is doing the great clinical work that you're doing in your spaces and helping facilitate opportunities for the students to be involved in meaningful patient care, whatever that looks like in your setting. So be a great role model, bring the student along, let them see it do, and the learning is going to come. And we're going to spend so much time on details today. We've gone through so much detailed data already in this first hour, but I think you can breathe a sigh of relief that the most important thing for you to do is to show up and do what you're already doing. Students value feedback and coaching highly, and this longitudinal trusted relationship opens the door to give meaningful growth feedback for students. And so do it often, do it in the moment. We'll give you some practical tools for how to do that upcoming. Assessments from preceptors are absolutely essential to the making sure that our students are progressing appropriately and making sure we can assign grades appropriately at the end of the year. So high value assessments, accurate, high value, timely assessments from the students are huge. And Dr. Adams is about to give you a bunch of specifics about how to do that. And then get to know your students as learners and people. A lot of the value of this comes from the relationships that are built between students and preceptors. And so investment in that space is going to pay off over the course of the year. So everything's going to go great. You've got all the tools that you need, but what if it's not going great? What if your student is not doing well? What if you're not sure if they're doing what they're supposed to be doing? What if you have questions? The good news is that each local LIC environment has a ton of people for you to check in with if you're not sure, or especially if you're worried about the student. The LIC director is a great person to start with, the coordinators and liaisons. Anybody in the LIC leadership program in your local site can filter your question to the person that it needs to get to, but anyone can help, and I'm certainly happy to help wherever. My email will be on the last slide of this presentation, and keep it handy and reach out to me if there are questions I can answer. In this model, it's really important if students are struggling, or if you're struggling to figure out what you should be doing, that you reach out early. Because students are moving through so many different spaces, we rely on active communication from all of those spaces to get a global sense of how the student is doing. So if something is amiss, something seems off, you're just not sure, please reach out early to any of us. And we want to leave you with some resources. And so we have developed a faculty guide that can be found at licguide.org, which has a ton of little short digestible chapters, really brief, that cover a lot of the stuff we just talked about and we'll go on to talk about in the upcoming sessions. There is a link in these slides to a testimonial video about teaching and learning. So if you want to know more about the benefits of the LIC that I just zoomed through, or if you want to show it to somebody else in your clinic, if your nurse manager is complaining about all these students around and you want to deliver some of the messaging about why the students are awesome and why we're doing this work, you can feel free to share this. And then finally, we've included a great article around some brief teaching tips for students in the LIC clerkships, which you can find at the bottom of the slide. So that's it. Thanks for bearing with me through a lot of information. Much more to come in the following sessions, and I'll be around all afternoon. So feel free to grab me to ask questions if you have individual ones. We're at the end of our time, but I'd love to leave just a little room before we start, if that's okay with Dean Adams, for questions for folks in the room or on Zoom. If you're on Zoom, you can put them in the chat or you can shout them out, whichever feels more comfortable.
Question from the chat.
Great.
The first one I think was mostly answered, because I think it was asked before you shared all the outcome slides, but just in case. How many years has this new model been in use at CU? Are there other schools using the same or similar model, and are there any outcomes data?
Yeah, so I think we shared a lot of outcomes data. We've had LICs at the CU School of Medicine since 2011, and we've been all LICs since 2022. We're the only school currently with all LIC model, but there are many schools who see our successes and the success of this program who are increasingly integrating LIC model, and many schools have some of their students in LIC.
And then another question was, how are disparities and variability across different clinics and preceptors addressed? Are there syllabi, topic lists, etc.?
That's a really great question. If you are, I would encourage you to connect with your local liaison to make sure you have access to all of the syllabi and all of the materials. There'll be a wealth of information for you to make sure that you get exactly what you need to know for your site. We develop all of those things through a lens of comparability from the top level, being able to compare the experiences and ensure that our students are meeting their key competencies and having exposure to everything they need to learn is something that's required by LCME and is a standard of all medical schools. And so that's super important to us and is measured at the level of the School of Medicine and above and tracked in many ways. So you can rest assured that that's at the forefront of our mind. And in terms of how you operationalize that, get in touch with your liaison. If you don't know who the liaison is, get in touch with your LIC director or coordinator, and they can point you in the right direction to make sure you have the most up-to-date syllabus and preceptor manual and all the materials that you need for the nuts and bolts. Great question.
How many patients are on their panel total, kind of?
The minimum number is 15. So they have to follow 15 patients for at least 3 touches. Lots of students will have many, many more than that on their panel, or some students will choose to keep a smaller panel but go really deep with the patients that they have and go to everything that they do. But a minimum of 15, with a proportion of those being any patient that they'd like to follow and a proportion of them being in categories to ensure that they see the breadth of broadly speaking, breadth of conditions. All right, great. Anybody who needs a little break, feel free, and then we're going to get Dr. Adkins here for the next talk.